All right, everyone. We'll go ahead and get started with today's presentation. So just a quick plug about the AMSSM Library of Sports Ultrasound Pathology again. So this is an opportunity to take the pathology that you see in clinic, in the training room, or the sidelines, and actually turn this into a publication. And so currently the AMSSM Sports Ultrasound Committee is looking for both common and unusual pathology related to sports ultrasound to highlight these cases. So it's a really great way for residents, fellows, and staff to add to the growing series of the library and the sports ultrasound pathology that is there. And this is actually a peer-reviewed reference for your CV as well, too. So more information can be found under the AMSSM webpage under the sports ultrasound tab if you are interested in this. Otherwise, today I'm going to be introducing our speaker, which is Dr. Romero. So he is currently a sports medicine fellow at the Mayo Clinic in Rochester, Minnesota. He completed his medical school at the University of New Mexico School of Medicine, and he has now followed this up doing his preliminary year in the Department of Internal Medicine and subsequently his PM&R residency at the Mayo Clinic in Rochester, Minnesota. He's actually going to be staying on as an assistant professor of PM&R at the Mayo Clinic in the Division of Sports Medicine after fellowship. And he has been actively involved in the AMSSM, serving as the Sports Medicine Resident Council President. And now he's the fellow liaison to the Ultrasound Committee. And in the future, Dr. Romero has a strong interest in medical education, diagnostic and interventional ultrasound, orthobiologics, and comprehensive sports coverage. So really looking forward to his contributions in these areas in the future. And today he's actually going to be discussing a case then on Latissimus Dorsi and Teres major injury. So Josh, I'll let you go ahead and start sharing your screen.
Okay, great. Thank you. Let's see. Okay, just want to confirm you can see the screen looks okay and you can hear me.
Yep, see and hear you perfectly. Thanks, Josh.
Okay, great. Thank you. Well, thank you very much for that introduction. I really appreciate the opportunity to be here this morning. So for those of you joining this morning, appreciate your time. And for anybody who watches this later on YouTube, hopefully you find this helpful. Before I get started, I first want to thank Dr. Brennan Betcher for his integral help with this case, as well as his mentorship during this process. I also want to thank Dr. Shea for his allowing me to present this morning, as well as Andy Meyer for his all his help leading up to this presentation. So with that, we'll go ahead and get started. So as mentioned, I'll be presenting a case of Latissimus Dorsi and Teres major injury for today's ultrasound case presentation. I don't have any financial disclosures or any conflicts of interest to report. So for our objectives this morning, we're going to describe the ultrasound protocol for complete shoulder examination. We're also going to describe the sonographic findings of Latissimus Dorsi and Teres major injury. We're going to review the ultrasound report for this specific case, and then we're going to end with a group discussion as is similar to previous presentations. So let's start with our clinical case. So we had a 27-year-old gentleman who was a competitive CrossFit athlete who came to our sports medicine clinic. He had pain in which he pointed to the right axilla, and this had been present for approximately 1 year. He recalls about 1 year ago when he was performing ring muscle ups. During the eccentric portion of that movement, he really felt a sharp pain. He was fairly limited thereafter for several months and had difficulty with any pulling movements or even overhead press. He modified his activity and completed some rehab on his own. And then after engaging in another competition several months later, he had recurrence of pain, which prompted his evaluation in our clinic. On his physical examination for inspection, he didn't have any ecchymoses in that area, didn't have any muscle atrophy in his posterior shoulder girdle, and there was no visible defect. From a range of motion standpoint, this was full, but he did have pain at the end range of shoulder flexion and abduction. From a palpatory standpoint, he had tenderness at the latissimus dorsi and teres major myotendinous junction, as well as the insertion. But beyond this, there were no other focal areas of tenderness. Looking at his rotator cuff, acromioclavicular joint, and labral and labrum, all the provocative maneuvers for these particular regions were negative. And then his neurologic examination was unremarkable. So we obtained shoulder radiographs, and I will just point out you can see there's little bit of an osseous irregularity here, but beyond this, we see preserved glenohumeral joint spaces. We see preserved acromioclavicular joint spaces. We don't see any cortical irregularity along the distal clavicle. So really, these were grossly unremarkable from our standpoint. So getting to the sonographic evaluation of the shoulder. So first of all, before we get started with the examination itself, we first need to understand how we're going to be positioning the patient and then what transducer will we be using. So from a patient positioning, there's some variation on how this is performed, but realize that the shoulder examination is really quite dynamic and it's going to require you to use multiple positions. So when doing the anterior examination, I like to have our patients lying supine and we have the forearm supinated. When we're doing the posterior shoulder girdle examination, we usually put our patients in the lateral decubitus position. Now, there's variations. Some people do this examination sitting up. And so certainly this is up to the sonographer's preference, but we find that if we're doing this longer examination, this is a little more comfortable for patients. Additionally, when we're looking more at we're evaluating the supraspinatus, we put the patients in the modified CRAS position, and this allows gravity helps to pull this elbow so it's more internally rotated, and so that helps from that standpoint as well. Next, when you're thinking about doing an examination, the choice of transducer is really an important step, and so certainly keeping in mind the shoulder has both superficial as well as deeper structures, as well as if you have somebody with a larger body habitus or muscular body habitus, that will also influence your choice of transducer. So for our examination, we use both a high frequency and mid frequency transducers. So looking at the complete shoulder scanning protocol, this has been presented in other lectures, so I'm not going to go through this in depth, but nonetheless, these are really the structures that we think about from a complete shoulder examination. Now, I realize when we're looking at tendinous portions, we really want to examine these both in the transverse and longitudinal planes, and so these have been listed here. Now, again, we know that pathology in the shoulder can be quite complex and that there's multiple structures in that area. Therefore, these are additional structures that you could consider adding to your examination. An important piece of this is developing a region-specific protocol and thinking about your differential diagnosis. So really using your history and your examination to localize and help to create your differential diagnosis, and then adding in some of these structures that you think might be helpful. So based on our history and clinical examination, we felt that really adding the pectoralis major, Latissimus Dorsi and Teres major were going to be helpful based on our differential. So getting starting with the examination. So we're starting with the biceps tendon in transverse. So we can see this is the biceps tendon in the rotator interval. And then we can see that this is the biceps tendon in the bicipital groove. And we don't see any fluid in this area. We see really a preserved architecture. So we call the biceps tendon normal here. And we're gonna look at this again. You always wanna look at this in both transverse and long. And so we can see again here, preserved architecture of the biceps, and we don't see necessarily any cortical irregularities of the humerus. And so we called that normal. Going to the subscapularis tendon, now recall that this has really a quite large insertional footprint. And so you really need to examine both the cephalad and caudal portions of this tendon. So this is looking at this in long axis. And so we can see on the left, this is the more cephalad portion of the tendon. And really that looks normal here. Now, looking at the more caudal portion of the tendon, this catches our eye here. And so this looks like a focal hypoechoic region involving the central articular footprint. And so we want to keep this in mind as we look at this in the transverse plane. So we measured this, and this was 0.42 centimeters. So we're going to keep this in mind. So now as we look at this in transverse, so realize that again, it's really a quite broad tendon. And so we can see the most superior fibers here, and then we see the most inferior fibers right here. So again, what we see is we're scanning from medial to lateral. This is more lateral here. We can again see this focal hypoechoic region involving the central articular footprint. Okay, and so we did measure this, and so we can see that the anterior to posterior distance, the anterior to posterior distance is 0.24 centimeters, and then the medial to lateral distance is really 0.33. And so now we've measured this in 3 different planes. And so we see that this focal hypoechoic region likely represents a partial thickness tear involving the deep fibers here. So let's keep going. So now evaluating the acromioclavicular joint. So really we see no capsular distension here. We don't see any cortical change involving the distal clavicle, and we really see preserved joint space narrowing. So we call this a acromioclavicular joint normal here. Now, looking at the infraspinatus, so certainly this and the teres minor can be somewhat challenging tendinous structures to identify. So being very intentional with your examination here is important. So we can see that we're looking at the more medial aspect of the fibers here, and so realize that you're going to the insertional footprint is going to have some anisotropy, and so you really need to heel toe to bring those out. So really wanted to highlight here that looking at the more medial portion of the tendon, and then as we heel toe, we can clearly see the insertional footprint here. And so really, again, we can see that at least in this axis, this looks normal. When we evaluated this in the transverse plane, what we're doing here basically is we're scanning from the muscle belly to the myotendinous junction out to its insertional footprint. And so we can clearly see that this is the infraspinatus because of its characteristic tendon. And we know that this tendon is central. We also know that it's been described as having a quote unquote seagull appearance. And so you can kind of appreciate that right there. So as we're scanning lateral, you can clearly see that the muscle belly looks normal, tendinous junctions look normal. And as we follow this out to its insertion, this all looks normal to us here. And so again, based on that looked normal, based on that evaluation. Now going to the teres minor. So again, usually we did take cines of this, but looking at following that teres minor out to its insertional footprint in the transverse plane. And so this looks normal here, and realize that the teres minor tendon is more superficial. And so that's one way you can identify it relative to the infraspinatus. Again, and we see that the insertional footprint from a long axis perspective looks normal here. Now getting to the posterior glenohumeral joint, so really looking for any intra-articular effusion here, and this looks normal here. So it's always important to include the relative joint for whichever area you're scanning. Dr. Doug Hoffman certainly talked a lot about this in previous lectures, and so always make sure to include that when you're looking for really any examination of any region. Spinal glenoid notch, we don't see any cysts in this area, so again, would call this normal. Now getting to the supraspinatus. Now, again, this is another area that's really important to be very meticulous and when you're interrogating it, but certainly looking at the transverse axis here. So what we're doing is we're basically scanning from medial to lateral here. And I want you to point your attention to right here. Let's see. And so what we're seeing is a focal hypoechoic region, more involving the anterior footprint, and we're seeing a linear dystrophic calcification right there. And then we can also see subjacent cortical regularity right there as well. So in a still image in long axis, you can see this linear dystrophic calcification right here. And so we call this a focal hypoechoic region with a subtle linear dystrophic calcification at the enthesis with subjacent cortical regularity consistent with either focal tendinopathy or partial thickness articular sided tearing. So now that completes really our standard shoulder examination. So as I mentioned in that previous slide, there's many additional structures you can evaluate. And so based on our differential diagnosis, we wanted to make sure that we included both the pectoralis major tendon, latissimus dorsi, as well as the teres major. So now the pectoralis major is really, that anatomy is really quite complex, and it's been described in previous papers. It's also been described in previous AMSSM lectures. So there was a lecture by Dr. Whipple 2 years ago, and then a lecture by Dr. Visco as well. So I'm not going to go through this in depth just because it deserves its own attention. But nonetheless, we looked at the long axis portion of the tendon, and we looked at really this in transverse plane. And what we found is that the sternoclavicular heads really appeared normal. And so didn't see any pathology in this region. So again, our leading hypothesis was that this gentleman was going to have a latissimus dorsi teres major injury. And so because of that, I want to take just a few minutes just to review the anatomy here, because I think it's important for us to review that. This is certainly not an area that I scan very frequently. And so I think and I imagine many others as well. So I think it's worth reviewing some anatomy here. So recall that really the latissimus dorsi is really a large muscle, and it also has quite a long tendon. So the origin, it's because it's such a large muscle, it does have multiple origins, and so the origin includes the spinous processes, the T7 through L5, spinous processes, so T7 through L5, the thoracocolumbar fascia, the iliac crest, the lower 3 to 4 ribs, as well as the inferior angle of scapula. And realize that the insertions on the medial aspect of the caudal intertubercular groove on the humerus. An important piece, and we're going to look at this here shortly, is this has really a long tendon. So it's been described as having a tendon as long as 7 centimeters. And also realize that the latissimus dorsi and teres major are really intimately related. So just looking at even this example, you can see here's latissimus dorsi here, and then just posterior, you're going to see that's the teres major. So now looking at the teres major, we know that the origins off the inferior angle of the scapula. And insertion being, again, the medial aspect of the caudal intertubercular groove on the humerus. And again, just pointing your attention to, now we can see latissimus dorsi here, and then there's the teres major. So let's dive into this a little bit deeper. Well, I first want to thank Dr. J. Smith for sharing these images with us, but this is just a little global view of what we're looking at here. So you can clearly see when we have the arm abducted here, we can see the latissimus dorsi becoming tendinous here, and then we can see the teres major in that area right there. This is a little more close-up view, but these next pictures are going to be a little more helpful. So look and see that you can clearly see that this transitions from being muscular to tendinous right here. And you can see that really the latissimus dorsi tendon is really quite thin and has a fairly large footprint. Now, look how that contrasts to the teres major, where the muscle, it goes, the muscle, it's more muscular, and it really has a much shorter tendon. And then look how intimately related the latissimus dorsi and teres major are. You can clearly see that those tendons are really basically stacked on top of one another. And so this is really important, keeping this keeping this in mind as we're scanning, because this really is going to help determine what you're seeing on ultrasound. So when you're thinking about what should we look at when it comes to the latissimus dorsi and teres major, can we look at some previous protocols that have been developed? And if we go looking into the literature, really it leaves much to be desired, because really there's when you look at the literature just for these injuries in general, there's been a little over 25 case reports, about 2 case series, but really there's not a lot written about the sonographic findings of these injuries, and so there's certainly much to be desired in terms of research in this area. So this was a study back in 2011 that looked at the sonographic findings in MRI and latissimus dorsi injuries. But beyond this, there really is not much written in the literature. That being said, Dr. Kendall has previously presented about these injuries at AMSSM. And so our understanding of these injuries certainly comes from a lot of work that he's done. So when we think about the structures to scan, we think about looking at the humeral insertion of these tendons in long axis, as well as the transverse plane, look at the myotendinous junction, looking at the muscle belly, and then also getting extended field of views, because again, these are both larger muscles, or what I'll refer to as EFOB moving forward. So what we're going to be doing here is I've put a reference here. We're going to be starting here. And so we're going to be starting at the inferior angle of the scapula. And so here we can see the teres major blooming here, and then this is the latissimus dorsi up here. As you watch this, you can see it clearly it becomes tendinous quite quickly, and you still have teres muscle below. Now, if we look at these caudal fibers here, you can clearly see that there's going to be an architecture change right there. Now, realizing this particular view, we're really trying to just get a global view. We're trying to just see what's happening from a global standpoint. Now, once we see some pathology, we're gonna hone in a little bit more on that area. So now this is teres major. So now we're honing in on that area. We're clearly seeing a disruption in the architecture here. We see some fluid defect in that area as well. These fibers look to be normal, but certainly involving those caudal fibers, you can clearly see that clearly looks to be muscle or a fiber disruption in that area. So let's keep going. And basically just wanted to show that here, this is basically the transition of how we're completing this. So this is the extended field of view, or the EFOV. And so here in the lower screen, I have the left side for comparison. And so looking at this, we can clearly see that this is the latissimus dorsi, and then here's the tendon. Again, recall that that tendon's quite large. Contrast that to, we can clearly see that here's a delineation. Here's the teres major, and again, with a very short tendon there. Now, here is the right side, so the side that was abnormal. You can clearly see that the latissimus dorsi tendon is thick relative to the left side. And then we can also see that there looks to be some hypoechogenicity in this area, and also some fiber disruption involving the inferior portion. We can also see at the myotendinous juncture that looks to be a full thickness tear as well as a retraction of that teres major muscle. So this comparison helps us to understand these two sides relative to one another. Now, if there's ever any area you have difficulty scanning, it's always helpful to scan the contralateral side of the quote unquote normal side, so that way you can get a just basically a reference on what's normal. And so I would always encourage people to do that if they're scanning an area, if there's ever an area in which you don't scan very frequently. So now we did measure this, and we found that there was about approximately 2.1 centimeters of retraction from its humeral insertion. So now looking at this, looking at the humeral insertion in the transverse plane. So what we're going to be doing here is starting at this is the humeral insertion here. We're going to be scanning medially. And again, you can clearly see, pointing your attention here, there's clearly a fluid defect right there. And look how this contrasts to what you're seeing in here. And so certainly, again, looking at those most inferior portions or caudal portions, particularly at that myotendinous junction, and as you come to its tendinous insertion right there. Okay, so now looking at this in long, what we're doing here is we are scanning from and realize an important piece to look at here is realize when we're positioning the patient here, we have the arm abducted and externally rotated. So the terminology becomes a little bit challenging on how to describe what location you're describing, because recall, if we think about anatomical location, and this would actually be theoretically lateral. And so in this position, we're referring to this because we're approaching more of a transverse plane relative to the humerus. So we did refer to this intermittently as cephalad and caudad. And so I just wanted to mention that terminology there. Nonetheless, so what we're doing here is as we scan from the inferior portion to the more superior portion, you can see again that fluid defect happening right in here. And as we're scanning up, one important thing is you're saying, so we're scanning more superior. Again, we see that these fibers look normal. And so, as I mentioned early on, it really has quite a large footprint. And so that's why you really need to scan both the superior and inferior portions of these tendons, because they're really quite broad. And so you can clearly see that the more superior fibers are normal in that area. So now looking at the humeral insertion, so these are just some still images. And so we can see, again, have a left for comparison, so the normal side, and then the pathologic side here. And you can clearly, again, see some thickening of this tendon. We've talked about this myotendinous injury here. And so I think this just really helps to paint these images in your mind about the normal side and then the abnormal side. So now what we did thereafter is we wanted to take a look at how the architecture changed or didn't change with both passive motion and then also with resisted motion. So what we're having the patient do here is we're basically having them do basically a resisted pull-up, if you will. And so basically involving some internal rotation, adduction. And so as we just had the patient passively do this, you can, again, drawing your attention to right in here, you can clearly see, again, that myotendinous injury that we've talked about. Play that back there. The myotendinous injury, that fluid defect. And then you can also see some disruption of these fibers, again, in the inferior portion there. And so that was just with passive motion. So then thereafter, we did the exact same thing, but now with resisted motion. So same movement, we just had a little bit of resistance. And so again, as we're doing that, you can clearly see some disruption of the fibers here, some hypoechogenicity. Again, we see this really brings out that myotendinous injury, that fluid defect again comes back out. And so this is looking, what I wanted to highlight here is we're looking really at the humeral insertion and the myotendinous junction here, at least in regards to the teres major. Now, as we're doing that exact same motion, but we're looking at basically myotendinous junction out to the muscle belly. And so we're basically taking a look to say, okay, we've really examined the insertion as well as myotendinous junction. We also want to make sure we take a look at the muscle as well. And so this is us just scanning and taking a look at the muscle. So that completed what I think are the images and videos that I think are most relevant to show from a sonographic standpoint. Now, we did end up getting an MRI, and I really wanted to include this because I think it's important to understand for injuries that we may not see that often, how do we compare and contrast different imaging modalities? So we obtained radiographs to get that comparison, and then we also got the MRI. Now, I ended up going and reviewing this MRI with one of our musculoskeletal radiology colleagues because I wanted to understand how do they think about these injuries and how often they see these. What I came to learn about was that these injuries, they also have not seen many of these injuries also. And so there's really not specific MRI protocols for these particular injuries. And I want to just highlight the benefits of ultrasound potentially to MRI here. So to draw your attention, it's a little bit challenging to delineate teres major from Latissimus dorsi here, but really, if I draw your attention to this area in here, this is really, we're getting to teres major and then Latissimus dorsi. And so you're going to, as we're scanning, you're going to see some, right there, you can see some myotendinous injury and some increased T2 hyperintensity in this region. Now, important thing to keep in mind is recall when we were scanning with ultrasound, we had the arm abducted and externally rotated, and so we're putting a little bit of tension on those two structures. When we're doing the MRI, their arms are adducted, and so they're not necessarily have these under tension, and so and that's just standard for the MRI protocols. So realize that if we would have to really change protocols to really examine the arm in an area that really puts a little bit of tension on this area. So that's one thing to keep in mind. And then just want to show you from one more plane here. So really this, I feel like you can mostly see teres major here, but really looking in this region. But again, an important piece to highlight here is really looking at the level of detail we were able to obtain from the sonographic findings versus what we're seeing on MRI. So let's get into the diagnostic ultrasound report now. So again, the indication was for shoulder pain / pain in the axilla, and we really wanted to evaluate for latissimus dorsi or teres major injury. For the transducers, we used both the high frequency and mid frequency transducers. Our comparisons were his previous shoulder radiographs. And then getting to his findings. So I'm not going to go through and read all of the normal findings. Everything that's abnormal has been highlighted in yellow. So from a subscapularis, we did talk about, and again, an important piece about this is that our hypothesis was really more latissimus dorsi and teres major injury. But if we didn't do a full examination of the entire shoulder, these additional areas of pathology we would not have picked up. Now, are these clinically relevant? That's a different discussion, but certainly at least we were very thorough in our examination here. So from a subscapularis standpoint, there was a focal hypoechoic region involving the central articular footprint with the following measurements. And we felt that this really was consistent with a non-retracted partial thickness tear. Getting to the supraspinatus, there again was an area of focal hypoechogenicity. There was a subtle linear dystrophic calcification, and then subjacent focal regularity. And we felt that this likely represented either focal tendinopathy or low-grade partial thickness tearing. Now, getting to the latissimus dorsi and teres major, I think that it would be best if I don't necessarily read this word by word, but really we examined both the humeral insertion, we looked at the myotendinous junction as well as the muscle. And so I'll leave this up for a second here, but really the findings were most consistent with a right teres major and latissimus dorsi injury. And we thought there was suspected full thickness tearing and at least partial width tearing of the teres major, and then partial thickness tearing of the latissimus dorsi, most involving the caudal or the inferior portion of the tendons. And then there was also, and then again, we've talked about the low-grade partial thickness tearing of both the supraspinatus and subscapularis. So in our description here, we did specifically talk about, as I mentioned, the tendon, any pathology involving the tendon, the myotendinous junction, as well as what we found with the muscle belly, and then what we found with passive range of motion as well. So we want to comment on if there's any dysconjugate or dyskinetic motion. And so we did talk about that. So in summary, it's important to be thorough in your sonographic evaluation and develop a region-specific protocol. And recall that you're really going to use your history and physical examination to help guide this. Understand really the close anatomic relationships of both latissimus dorsi and teres major tendons. And so those previous cadaveric images I've shown, I hope to highlight and send that point home. Realize that ultrasound is an effective imaging modality to detect both latissimus dorsi and teres major injuries. And currently, there are no studies that show the sensitivity and specificity or have comparison studies compared to MRI. But I really wanted to highlight our findings of our sonic from ultrasound perspective and how that compared to our MRI here. Also, it's important to be systematic in your approach to evaluating latissimus dorsi and teres major injuries. So being very, very meticulous with evaluating the muscle belly from origin to its insertion, myotendinous junction, as well as the tendinous or the humeral insertion. And with that, I want to thank everybody for their time and attention this morning. And I'm happy to open up for any questions and our group discussion at this time.
Wow, Josh, that was an awesome case, and just some beautiful images for these injuries as well. As you had mentioned, I think these are very under-recognized injuries, when it comes to sports. And I think one of the reasons being is because it's not always detected with the imaging modalities. As you had mentioned, I don't think it's really included in the standard MRI protocols. And so there's not that much literature to go off of, unless you kind of clearly delineate, very much like with pec major injuries. And then, as you had mentioned, I mean, they're just, when you go back and do an actual literature review for, sonographic findings for these injuries, there really isn't that many papers, nor is there any recent papers. So really appreciate you kind of going through and at least initially describing a protocol that can be used, for these injuries, just because, I think it is something that we can kind of really start to kind of pick up with the ultrasound, as you had mentioned, just highlighting the fact that there is, so many different positions and dynamic movements that you can do for these, muscle groups that can kind of aid in the diagnosis. So a couple of things that I would just kind of make comments off, that you kind of even highlighted as well too, is just having such an appreciation for the anatomy for this region. As you had mentioned, kind of the insertion of both the latissimus dorsi and teres major to that intertubercular groove for the humerus, and just knowing that the latissimus is going to be a little bit anterior compared to the teres major, but just knowing that they are going to be, very intimate, as you had mentioned, along that insertion. One thing that you had mentioned is the patient positioning, and to this point, once again, there really hasn't been that much described on what is the optimal positioning. But I think if you're definitely looking at that kind of tendon myotendinous construct, getting into that kind of wader tip position that you had mentioned is really key. But this is what makes this scan very difficult. I think you kind of have to flip back and forth with the patient going from anterior to posterior, especially if you're going to be looking at more muscle belly injuries versus myotendinous injuries, that you may scan, more posterior and have them a little bit internally rotated. But then when you're definitely looking at the tendon and myotendinous junction, I think once again, getting them into that wader's tip position is going to be really key. And then obviously using dynamic, motion along with that. And then lastly, as we had kind of discussed, is that these studies, there's not a lot of literature out on the evaluation of these injuries and describing them. But I think, as your case highlights, is I would not be intimidated by these injuries. Just start to take a look, with your clinical indications, and they're just like any other type of, muscle myotendinous tendon injuries. We know how to describe those for other areas. So if this ever becomes in question, just know your anatomy and know how to describe these injuries, and kind of do a thorough evaluation. And I think we can, start to really pick up on this, kind of add into the diagnosis of these injuries with the ultrasound, as this case clearly, highlights. And once again, hopefully you guys will publish some of these images, just because there isn't, too much out there on these injuries. But otherwise, now I'll kind of open it up to any other kind of comments or questions that anyone else may have.
Yeah, Josh, this is Doug Hoffman. Um, Great job, as expected. First of all, so the lat dorsi teres major complex is intimately involved in the area of what we call the quadrilateral space from the anterior approach. And I need to give Jake Sellen and Jay Smith a ton of credit for those dissections and sort of working out and positioning, because when you position your arm overhead, which is another modification of this position, everything gets flipped upside down. And so the anatomy can get hard. And so their work, Jake's and Jay Smith, is just been really invaluable. And I also got to credit Brett Kindle. He sees probably the most of these of all of us. And I really credit him with that EFOB view, because he just showed some beautiful views and patients of his. So again, I want to just give a shout out with that. You know, we talk about the normal protocol for the shoulder and then these reach areas. And of course, this is one of those reach areas. And again, I'm sort of lumping the lat dorsi teres major with the anterior approach to the quadrilateral space, because they're all right there. And for me, familiarity with this area has had several advantages. In fact, I just saw a lat dorsi tear a couple months ago.
Hmm.
First of all, it gives us much better access to the axillary nerve. So for any way you ever want to inject the axillary nerve in the anterior quadrilateral space or take a look at it, again, that's an advantage of it. But another advantage that I have found is in this position, I can see the whole musculotendinous junction of the subscapularis. And so if you're waffling it off, there's a subscat tear or thinning, kind of we do with the rest of the rotator cuff muscles. The positioning can help visualize the complete musculotendinous junction of the subscap. So that's been an advantage for me. If you're just starting out in this, you know, one of the nice ways to uh, just get familiarity is go to your sagittal view when you're looking at the teres, or we're looking at the infraspinatus and teres minor muscles. So most of us are familiar with that. And if you slide your probe, and if the patient is prone, and then you slide your probe laterally, you're going to see, as you slide it just laterally, you'll see the long head of the triceps come in, and the long head of the triceps splits the teres minor and the teres major. So that's just a really nice way then to pick up the teres major, which will be deep to that on ultrasound, and then you can follow the teres major and long axis. So that's just a nice way of, if you're just a little bit overwhelmed and want to get started scanning this area, it's a nice way to start. And then just the last comment on EFOB views, they are just invaluable. And whenever I can perform an EFOB view, I do. And one of the advantages of that is when we are presenting this to our surgical colleagues who have less familiarity with ultrasound. And again, oftentimes I just have to trust what we say. They have no idea, what we're looking at. Everybody can wrap their head around an EFOB view. And it's just a really nice area. And Josh, when you showed the comparison and contrast with an MR, and this is where ultrasound excels for this injury, is that we can get a perfect long axis view of the whole musculotendinous junction, and everybody can just wrap their head around that, where MRs can be difficult to do that as well. So again, Josh, really well done.
Well, thank you. I really appreciate the commentary from you both, and yeah, certainly, I think that EFOB view, even from somebody that really had not scanned this area very much, I think that really helped a lot, and so I agree. I think that's really a helpful area. So, yeah, I appreciate your commentary.
Hey Josh, it's Jake Sellen. I just wanted to say great job, and some great comments on this really challenging area. I mean, Brennan's scan was fantastic on this, but a couple things from the anterior side for when you're getting into this. One thing that has helped me is taking a look at the humerus in a transverse plane in that externally rotated position that you guys used. And if you take a look at the radial nerve, it's a nice marker because it will pass superficial to the lat tendon. And so that can be a nice a nice visual as you're scanning up and down the medial side of the humerus. And if another tip is, as you get proximal, you can distinguish between the lat teres major complex and the subscapularis by the underlying articular cartilage that you'll see on the humerus when you hit the subscap. And so that transition between subscapularis and long axis and the lat teres major complex and long axis is a nice area to also get into the anterior quadrilateral space, because that's right where the axillary nerve and posterior circumflex vessels will pass from anterior to posterior right there. So kind of like Doug said, that all that stuff is kind of tied together in that area, and obviously really challenging. You did a great job presenting it, so thanks.
Hey,
Thank
Jake,
you.
when you, I often will have these patients on the opposite lateral decubitus side. Do you do that, or do you have these patients supine?
Well, I think there are advantages to both, but I will typically start supine, and then as I'll start supine with the patient just in an externally rotated kind of semi-abducted position. And then as I get further proximally, like as you get into the quadrilateral space, I think it's helpful to put the back of the hand on the forehead, kind of in that position where they get a little bit more abducted. And I think that I like to start though closer to the and not as abducted position, because as Josh said, as you move away from that anatomic position, it starts to become a little bit of a mind bender. And so I like to just kind of move into that position gradually, start from a position that I feel comfortable with the direction of everything anatomically. And then as I'm transitioning proximally, I'll eventually, like in the quadrilateral space, actually put the back of the hand on the forehead, and that seems to put people in a nice position for scanning in the quadrilateral space.
Mm-hmm. Yeah, and I agree in that. I usually start in the lateral decubitus, but it depends on the shoulder protocol. But yeah, I agree that if I start with the hand overhead, which is where I end up, it can get confusing. So it is nice to start in an anatomic position, or a position where the anatomy is a little more clear, and then go from there.
I think for a lat injury, like lat teres major injury like this, though, I agree. The lateral decubitus is nice because you can kind of transition from anterior to posterior, like Stephen mentioned, looking at both tendon and muscle.
Mm-hmm. Yeah.
All right. Well, unless there is any other comments, then we'll go ahead and close this out. Once again, we'll have another case in 2 weeks, which will be looking at a perimeniscal cyst. So thanks again for everyone joining in. And once again, thank you for the awesome presentation, Josh.
Yeah. Thank you for the opportunity. I really appreciate the group discussion.